Hello, guys. Good evening, and welcome to another lecture section on manipulative therapy. Today, we'll be discussing McKenzie method, and I'm your tutor. Uh, my name is Professor Oluwaleke Shokunbi. I'm a professor of orthopedic physiotherapy, MSK, and manual therapy. All right, so I'll be taking you today on the topic McKenzie method. Now, our learning objectives. At the end of the lecture today, I hope that everyone will be able to understand the aims of McKenzie method, the principle, the classification, assessment, and treatments method by McKenzie. We should also be able to know about the contraindication to McKenzie method of treatment. We're briefly going to talk about the man McKenzie himself. The man McKenzie is a physiotherapist. He was born in New Zealand. His full name is Robbie McKenzie. He was born in 1931 and he lived till 2013. So he was still with us about 12, 13 years ago. He was a physical therapist from New Zealand, like I said. And his method of treatment of spinal and peripheral pain, particularly the spinal pain that he introduced, is also known as mechanical diagnosis and therapy, MDT. So whether you heard of MDT or you heard of McKenzie method, they simply mean the same thing. Now, McKenzie method, among all other methods used in physical therapy to manage this pain of the spine, emphasizes classifications of the different type of pain based on the manifestation and matching the right treatment to each classes of low back pain patients. It also emphasizes self-management by the patient via comprehensive patient education. It emphasizes postural re-education and prevention of recurrences. So those are the things that are special about McKenzie method of treatment. The aim of using McKenzie will be to reduce the pain or to abolish the pain altogether. Or in a term of McKenzie, we can say to centralize the pain or to facilitate complete recovery from the pain. We are going to explain the meaning of the concept of centralization and the other relevant terms used in McKenzie in the course of this lecture. McKenzie also hope to be able to prevent recurrence of symptoms as well. So when using McKenzie method, you've got to think of breaking the treatment down into 4 stages. We have the assessment phase, classification phase, treatment, and prevention phase. These are the 4 stages that are involved in the use of McKenzie. So we're going to discuss each of these stage one after the other. So we need to emphasize assessment. Now, you and I know that as a physiotherapist or healthcare provider, we take a lot of decisions. We take decision about diagnosis of the patient. We take decision about plan of the treatment and method of treating the patient. How do we discharge the patient? But we cannot take all these decisions without doing comprehensive assessment. And the same thing applies to McKenzie method. So what sort of assessments do we commonly carry out in manual therapy? The kind of assessment we commonly carry out will include history taking, or what we call subjective assessment, where we ask the chief complaint of the patient, the history of the present complaint, their aggravating, alleviating factors. We go on to ask about the medical history, about surgical history, about occupational history, family and social history. And when we're done with history taking, we do our quick system reviews and we go into physical examination where we do inspection and observation, palpation, movements and measurements, and we carry out some special tests and we'll be able to get the diagnosis and plan the treatment. Now, this is a conventional musculoskeletal synopsis of assessment. Now, McKenzie also agreed with that. If you are using McKenzie method of treatment, you will do the same, like I've just summarized. But in addition, McKenzie emphasized about 3 or 4 points during the assessment that every physiotherapist should take care of. Now, what are these 3 or 4 points that McKenzie emphasized? The first one during your subjective and objective assessment, you must be able to establish that the pain with which the patient is presented with is a mechanical pain. All right. And what's a mechanical pain? A mechanical pain is a kind of pain that changes with posture and movements. In some patients, moving in one direction make the pain better. Moving in opposite direction make it worse, or it could be vice versa. In other patients, as long as movement can affect the pain in any way, in any known direction, is a mechanical pain. Mechanical pain are also affected by posture. Some patients, when they stand for too long, the pain is worse, but immediately they sit down, the pain eases off. So posture also changes the pain. So it's only this type of pain that would be amenable to mechanical diagnosis and therapy. So McKenzie emphasized that during our assessment, we should be able to establish that the patient is having mechanical type of pain. A non-mechanical type of pain presentation could be with spinal pain. And when you ask them to do flexion, the pain could be 8/10. Extension still remain at 8/10. Side flexion, right and left side flexion, the pain still remain at 8/10. And when you try to assess them in different planes, the pain is just the same. So that means movement has no effect, has no impact on that pain. So that kind of pain could not be a mechanical pain. Patients could also complain of, like, when I'm seated, I'm feeling the pain. When I'm lying down, the pain is there. I can't even find a comfortable position to lie down to sleep. So no position, no posture is making the pain better. So that is not a mechanical pain. And such a kind of pain is not amenable to treat. It's not going to be it's not going to progress, or it's not going to be made easier by using mechanical diagnosis and therapy. So it's only the mechanical type of pain that will be amenable to mechanical diagnosis and therapy of McKenzie. What's the second point? I said about 3 or 4 points you want us to take note during our assessment. The second point, McKenzie wants us to establish whether or not there is end of range pain. Now, what do we call the end of range pain? Normally when patients with spinal pain comes to our clinic, what do? We ask them to, when we get to the movement and measurement aspect of physical examination, we ask them to do forward flexion. That's they should bend forward like this. We ask them to do extension like this. Then they do side flexion and they do rotation, isn't it? And that's where it stops. Then we move to other area of assessment. But when you are using McKenzie method of assessment, beside the singular flexion, extension, side flexion, and rotation, you will have to take note while they are doing the flexion. You will have to take note why they are doing the flexion. What is the characteristics of their pain? Do they have pain at the beginning of the movement here? Or do they have pain towards the end of the movement? Or do they have pain at the very end of the movement, like we have in this diagram? So any pain that comes towards the end of the movement will be termed end of range pain. And that end of range pain could come with flexion. It could also come with extension. So extension end of range pain will be a pain when the pain is doing extension, just like we have on this diagram with my cursor. So firstly, McKenzie wants us to establish it's a mechanical pain. Secondly, McKenzie wants us in the assessment to establish that whether or not there is end of range pain. We are still going to talk about the importance of all these features very shortly. Thirdly, in the course of using McKenzie assessment, and we've got to the point of measurement and movement and measurement, McKenzie wants us to carry out a repeated movement test. What's a repeated movement test? Rather than doing single bouts of flexion, extension, side flexion, and then we stop, McKenzie actually wants us to establish whether or not, if the patient is asked to do the repeated movements of flexion, like 5 times or 6 to 10 times, what's the characteristics of the pain? Is the pain the same? Will the pain increase? Will the pain reduce? And if we make the same patient to do extension repeated movement, will the pain remain the same? Will the pain increase or will the pain reduce? McKenzie wants us to establish this fact as well. So it could be that you have a low back pain patient. You've assessed flexion, extension, lateral flexion, and rotation. Now you now ask him to repeat 6 to 10 of flexion, although you have to tell him that he will have to stop if the pain is too much that he cannot continue. But on doing 5, 6 forward flexion, the pain is getting easier and the patient could also go up to 10. So, and then you ask the same patient to do extension, but the patient could not do up to 2 or 3 because the pain is aggravating. So we will say that we have carried out repeated movement test. And as a result of the repeated movement test, we have now established that this patient has preferential direction. So what will be the preferential direction for this patient that we have mentioned? That will be flexion, because repeating flexion is what eases the patient pain. Doing repeated extension make the pain worse. You could also have another patient that while he's doing the repeated flexion, the pain is worse. And you now ask him to do repeated extension and the pain become easier. So we said the patient is having extension, preferential direction. Now, during that repeated movement test as well, another thing that could happen is the concept of centralization and peripheralization. Because some of the patients that we see for spinal pain, whether cervical, lumbar, they also have their pain being referred to either the upper extremities or the lower extremities. If the pain is referred to the upper extremities, and as a result of the repeated movement test, the pain in the thumb and the wrist is no longer there. It's now just in the elbow. The pain has moved from further distance to closer to the body. We will say the pain has centralized. But if the pain initially is in the shoulder and the neck, but as a result of repeated extension movements of the neck, the pain has now moved away from the shoulder and is now in the finger. So you will simply say that the pain has peripheralizes. So let me put it together again. During assessment, McKenzie wants us to establish whether we are dealing with mechanical pain or not. He wants us to establish whether or not there is end of range pain. He also wants us to carry out what? Repeated movement test. And during that repeated movement test, we should watch out if there is a preferential direction and if there is centralization or and peripheralization. Now, the note we have on this slide is just telling us that conventional physiotherapy assessments, that's without McKenzie, is a single flexion, extension, side flexion and rotation. However, in McKenzie approach, you have to do repeated movement test, whereby you ask the patient to repeat forward flexion and extension, either in standing or in lying or both of them. And you'll have to take note of preferential direction or directional preference. And you have to take note of whether there is centralization or peripheralization. An illustration of that is what we're having in this diagram. If you look at this diagram here, you see here the subject is standing and is going into extension, coming back and going, coming back. That's why you have the arrow going to the right and to the left. So you keep doing what's on the right and the left, and you keep watching on the countenance of the patient. If as the patient is going, you notice the pain is increasing or the patient is struggling to do the movement, then you can stop the patient. So that means repeated extension in standing is causing more pain. But it could also be that as the patient is doing, he's enjoying it because the pain is actually coming down and the patient is happy to go up to 10 movement. In which case, we are going to say that repeated extension in standing make the pain easier. All right. So you will also have to carry out repeated flexion in standing, coming from this point and going down. Then you have the arrow going to and fro like that. And the patient will have to repeat the process like 6 to 10 times. And you can take note of whether there is directional preference. You also have to take note whether there is centralization or peripheralization. That the repeated movement tests we can do include repeated extension in standing, like you have this subject doing, repeated flexion in standing, like we have this subject doing. It could also be carried out in lying position. So when we finish with repeated flexion in standing, extension in standing, then we go into lying. Repeated extension in lying will commence from this position of prone lying on the elbow, coming into straightening the elbow in extension with full prone lying, and the process will be repeated 6 to 10 times, and you ask the patient of the symptoms. Is the symptoms getting worse or is getting better? If it's getting better, that's a directional preference. If the symptom is moving from distal to the proximal part, that is centralization. So we have to take note whether there is directional preference or centralization or peripheralization during repeated movement tests. Repeated flexion tests could be carried in line. Repeated flexion tests in line could be carried out as illustrated in this diagram. Patient grabs the back of the knee and pull them to the chest from here to here, and then repeat again 6 to 10 times. All right, and then the patient will give a report of how the pain feels, or whether there is centralization or peripheralization. Now, the step 2 in using McKenzie is the classification. After doing all our assessments, taking note of the 4 salient points that I mentioned to you. What are the 4 salient points again? You take note of whether the pain is mechanical or not, whether or not there is end of range pain. You take note of, you carried out repeated movement tests, and you notice whether there's a preferential direction or centralization and peripheralization. Then after you've done that, then you will be able to classify your patients into one of these 3 categories: patients with spinal pain, with postural syndrome, or those with dysfunction syndrome, and those with derangement syndrome. All right. Who are those with postural syndrome? Who are those patients with postural syndrome? Those are the kind of patient that when they are doing their repeated movement test, they will not feel any pain at all. In fact, they can come to your clinic and say that they are not feeling the pain at the moment, but while they are at work, they have a lot of pain. Or they can say to you that while they just wake up very early in the morning from the bed they sleep on, they're experiencing a lot of pain. Or while they are doing their work, they are feeling the pain. But immediately they stand up from work and they decide to walk home, they don't feel the pain anymore. Or immediately they wake up and they go to the shower, the pain just disappears. So it means certain posture is responsible for their pain. And immediately they come out of that posture, the pain disappears. So these are the categories of pain, neck, spinal pain patient that McKenzie classified as postural syndrome. All right, while they are in that posture, they feel the pain. While they are out of the posture, the pain disappears. Those are the postural syndrome type of patient. Their pain is particularly caused by mechanical deformation of musculoskeletal tissues that is held in a static position for a long period of time. Imagine like the picture we have on this slide, a patient that is walking, pressing the mobile phone, using his mobile phone in this position of brought forward position of the head and the shoulder, protracted scapula. All the musculature in the posterior aspect of the neck and the upper back will be deformed. Even though they were normal, they will be subjected to stress and deform because of that abnormal posture, and there could be pain. Patient could report pain because of that. But immediately that posture is reversed, their pain disappears. So these are the group of patients that McKenzie classified as patients with postural syndrome, simply due to posture leading to deformation of normal musculoskeletal tissues, but immediately patient leave that position, the pain disappears. Doing repeated movement tests on them, they don't have any pain at all. They might even complain to you while they're in the clinic that they are not feeling the pain now, but they felt it at one point or the other while they were assuming that type of posture. Now, what do McKenzie advocate on how we should treat this patient? McKenzie said this group of patients should be treated by educating them based on education. So we have to educate them. Educate them on what? We have to educate them on correct posture, on how to improve their postures, how to restore normal lumbar lordosis. When I mean by correct posture, improving posture, so we need to ask them questions about the particular posture that gives them pain. If it's a posture at work, then we need to do a complete office space ergonomic assessment on them, assess the ergonomic compatibility of their chair and table, the presence of lumbar lordosis, the distance of the screen from them, whether their feet, inclination, the back to chair, the eye to screen, the hand to mouse, and the hand to keyboard. We need to do a comprehensive ergonomic assessment on them and correct that faulty posture. If it's the way they sleep at home, then we need to ask the question about the mattress or the pillow they sleep on if they are presented with neck pain. A neck pain patient should not even use any pillow at all if possible. And if you use a pillow, it should be a very light feather pillow, not a very huge one that will force the neck into a kind of flexion, overstretching the muscles on the convex aspect of the neck, creating more pain. So McKenzie wants us to educate them on all this. They also need to be educated on avoiding any provocative posture. Any posture they adopt, they feel pain, they know it's time to change from that posture to a better one. And one other beneficial therapeutic intervention we can give to this patient is to carry out what we call postural overcorrection exercise, or POE. Because they have subjected their posture in one position for quite a long time, it is quite possible that their spine get deformed and the musculoskeletal structures in the position of convexity will get overstretched, and those in the position of concavity will get shortened abnormally, and that begins to create pain. So they need a kind of postural overcorrection exercise that we're still going to talk about in a short while to correct them. This is what I mean by office space ergonomic intervention. So if the pain is associated with work, so physiotherapists will have to visit the workplace and do a proper ergonomic assessment and intervention adjustment of the workspace in order to eliminate that posture. That will include setting the seat height, that will include setting the elbow support, or removing it completely, whether or not there will be needed for head and neck rest, setting the distance between the eye to screen, the hand to keyboard, the hand to mouse, and the feet to floor. All these sort of assessments will have to be carried out and addressed properly in terms of adjustment in order to prevent the postural pain. All right. Another thing, like I said, during the patient educations, to educate them, if they come with neck pain, on the kind of pillow they sleep on, right? If they're using a bulky pillow, it will probably force the neck into kind of side flexion. So there'll be concavity on one side, there'll be convexity on one side. Now, the side of the body that is convex will be subjected to a lot of stress and deformation, and that could come up with pain. And even the side of the neck that is concave in nature will get adapted to that shorting position or subjected to that shorting position for quite a while, and that can lead to sensitization of a lot of pain sensitive structure in that part of the body, which means the patient is going to wake up with pain. But immediately they move away from that pain, like I said, from that posture, their pain relieves. So we need to educate them on sleeping with a very light pillow or no pillow at all, or even putting the pillow below the mattress around where they are going to put their head. This is still to resolve postural syndrome. Dealing with postural syndrome also involves the use of lumbar roll. The person might not be an office worker, so maybe you don't need a proper office ergonomic assessment, but the person might not be sitting very well on the chair. Habitually, it might be used to sitting at the edge of the chair, so the back is inclined, and that could put a lot of stress, throwing the back into abnormal convexity, which will put a lot of stress on the posterior back musculature. So in that case, we need to teach and educate the patient on proper seated posture with the use of lumbar roll. Put the lumbar roll in the lumbosacral cuff, ask the patient to move the buttocks backward until the back touch the roll, and then throw the back on it. So proper sitting posture with support for the lumbar lordosis is part of the education and intervention that is useful for patients with postural syndrome. And the last one we'll discuss on postural syndrome here is the use of postural overcorrection exercise. You know what happens when they adopt this kind of abnormal posture is that the spine gets held up in that static position for a long while, That's not healthy for the spine. Even the cartilage and the intervertebral disc derive their nutrition from movements from the fluid into the disc. But when the spine is set up in one static posture like that, the rate of diffusion of those nutrients into the disc is reduced. Constant movements, of the joints, of the apophyseal joint, is what is responsible for faster diffusion of nutrient from the synovial fluid into the intervertebral disc. Anyways, so how do we go about the postural overcorrection exercise? Can get the patient to be seated like this. So the patient gets seated like this, drop the shoulder down, push the head forward, round the back. That's a very bad posture. And we're going to ask the patient to stay there for 2 seconds. But we're going to emphasize to the patient that this is not a proper posture. We're doing this just for the purpose of exercise. So we move from that slash posture to a chest out posture. That's the one in the middle one. Then from there, you ask the patient to do a proper chest out with shin tucked backward. Well, that looks good as well, but too much staying in this position for too long could also predispose the patient to pain around the shoulder and the upper back. So we'll now tell the patient to release this posture or reduce it by 10 to 15%. Well, the patient might still not understand that terminology, 10 to 15%. What we then have to say to the patient is to reverse this posture gradually until the shoulder and the neck muscle feel relaxed. So by the time the patient is relaxing or reducing that posture and he felt sudden relaxation around the upper back and the shoulder, that could be tantamount to about 10 to 15% reduction in the hyperlordotic posture. And that is an ideal posture. So the exercise involves coming from a slouch posture to a chest out posture to a normal or ideal posture. And we ask the patient to repeat this procedure 10 to 15 times, 2 to 3 times a day. So that will also help to keep the musculoskeletal structure around the area very healthy. And the final position attained will always inform the patient of the patient's ideal posture. Right? So these are the interventions that McKenzie advocated for postural syndrome. Now, what about dysfunction syndrome? What about dysfunction syndrome? What group of patients belong to this dysfunction syndrome? You remember at the start of the class, we talked about what McKenzie wants us to do in terms of assessment. And I told you that one of those 4 things that McKenzie wants us to sort out is whether or not the patient is presented with end of range pain. That's pain coming at the end, either at the end of flexion or at the end of extension. Now, this sort of end of range pain are usually caused by scar tissue. They could be caused by contraction of soft tissue. They could be caused by muscle tightness in different parts of the body. So that by the time the body moves into end of range, the scar tissue, the contractor tissue, the muscle tightness are pulled. And because they are already tight or contraction or the scar tissue, it will reproduce this pain. These are the group of patients that McKenzie classified as dysfunction syndrome. So dysfunction syndrome patients are patients that their pain is caused at the end of the range, either by scar tissue, tightened structure, or muscle tightness. And this sort of pain will usually come at the end of the range. It could be due to either tightness or scar tissue in the back muscles, in the gluteal muscles, in the piriformis muscle, as you can see in this arrow. It could be due to tightness of the hamstring. You remember that the hamstring is attached to both the hip and the knee. So if the hamstring is tight, it has a way of causing pain around the lower back. If piriformis muscle is tight, it can radiate pain around the piriformis area to the lower back. The same thing as the back muscles. If it's tight, it can make the patient to feel back pain without any other associated, with or without any associated pathology in the lumbar spine. So these are the patients that falls into the category of dysfunction syndrome. So if we have a patient that's reproduces pain at the end of the range, we know, oh, this is a dysfunction syndrome. Then what's the next thing that we have to do? We know dysfunction syndrome is due to scar, is due to tightness, is due to contraction. So the next thing we have to do is to find out where is the scar, where is the contraction, and where is the tightness, so that we carry out the appropriate therapeutic intervention to deal with that. And how do we go about that? How do we go about that? Let's say, for instance, we ask our patient to do forward flexion and it has end of the range pain. So that means a patient that's completed forward flexion and is having end of range pain implies that the tight tissue or the contractile tissue is on the posterior aspect of the trunk. In this case, it could be the lower back, it could be the piriformis, it could be the hamstring. If we ask the patient to do back extension that is having pain, it could be that there is a scar tissue or contraction or tightened structure in the anterior part of the body. And in this case, it could be the hip flexors that is radiating pain to the back. So we need to find out how to isolate those deformities. How do we find out if tightness is in the hip extensors muscles, like the glute muscles and the hamstring muscle? One of the simple tests we can do is called the prone hip extension test. So you ask the patient to lie prone, the unaffected leg remain fully supported on the plinth. The affected leg, the knee will be kept straight, and you advise the patient to lift that leg up towards the sky, and it should be able to get 10 to 15 degrees. If it's able to get 10 to 15 degrees without adjusting, if it's able to get 10 to 15 degrees without adjusting, without over arcing the back, then there is no tightness of the muscle around there. But if he has to move this leg up by causing arcing of this back, that might be due to tightness of the glute muscles or the hamstring muscles. So this is one of the tests we can do in a follow-up when a patient shows end of range pain with flexion. Another test we can do when a patient shows end of range pain with flexion is piriformis muscle tightness test. So in piriformis muscle tightness test, the side of the body that is having pain, let's say in this case it might be the left side, so you ask the patient to lie on the right side, on the unaffected side. So the affected side is uppermost, and the hip on the affected side where we suspect tightness causing end of range pain will be flexed. It will be flexed, it will be abducted and like internal rotated by pushing the lateral side of the knee towards the plinth. That's flexion, abduction, and internal rotation. So by doing this, the piriformis muscle will be stretched. So if the muscle is already tight, then patient will report pain around the posterolateral part of the buttocks, maybe with or without the pain radiating to the back. Then we can conclude that hamstring muscle tightness test is positive, and that tightness of hamstring could be associated with the dysfunction syndrome. It could be associated with the pain that the patient is feeling at the end of range of flexion. Right? The test you're seeing on this slide is an illustration of how to confirm whether the hamstring and muscle tightness is also associated with dysfunction syndrome. Some will call it active knee extension test. Some will call it 90-90 straight leg raising test. Some will simply call it hamstring muscle tightness test. They are all the same thing. Or some will call it popliteal angle test. So all the patient will have to do is to lie supine. The affected side of the pain, the knee, the hip will be kept at 90 degrees and the knee will be brought to 90 degrees. It could be active or passive movement. If it is passive movement, then the therapist will move the knee from position of 90 degrees, attempting to bring it to 180 degrees. The popliteal angle is the angle between the tibia and the longitudinal midline in the femur. This is the longitudinal midline of the femur, and this is the line of the tibia. So the angle between the two of them is what's known as popliteal angle. Now, normally, tightness of hamstring will want to stop this movement from reaching 180 degrees. And what usually happens is that from birth, The angle is about 180 degree full extension when a baby is born up to 2 years. But at the age of 2, after the age of 2, the angle gets reduced to 155, about the age of 6 years, and it remains like that. So when you try to put the hip in 90, knee at 90, and push the knee forward into further extension, and the patient could not achieve a popliteal angle is denoted by that brown arrow, and the patient could not achieve a popliteal angle of 155 degree, then it shows there's tightness of the hamstring. All right, 155 degree with 25 degree lag is still considered to be normal. But if the patient gets stuck at 90 degree or 110 degree, that shows there's an hamstring tightness that is capable of producing pain around the hip and the lower back. And that could be the source. That's one of the potential sources of dysfunction syndrome. Another potential sources of dysfunction syndrome could be the iliopsoas, the hip flexors. And that could be tested for by using Thomas test. Simply involve having the patient to lie supine on the plinth, and the supine line allowing the buttocks to hang slightly off the edge of the plinth, and the knee, one of the knee will be pulled towards the chest while the other leg is hanging freely. But as the patient pulls the unaffected knee towards the chest, if the hip flexors of the thigh resting on the knee is tight, the thigh will automatically jump up from the plinth. But if it is not tight, it will remain on the plinth. But if it is tight, it will jump off the plinth. All right, and that's an indication of hip flexor tightness. That could also constitute one of the sources of pain in patients with spinal pain, low back pain with dysfunctional syndrome. So how do McKenzie advise on the treatment of patients with dysfunction syndrome? Patients with dysfunction syndrome pain will have to be treated by addressing the scar tissue. If you notice any scar tissue, the scar will have to be treated either with frictional massage or ultrasound. If you notice that any muscle is tight, the muscle will have to be stretched. How is the muscle stretched? You push the muscle towards the size that reproduces the pain, and you hold it down there for about 15 seconds, and you repeat 5 to 10 times. That's what we call direct manual therapy. You move the body in the part that produces the pain, you hold it down for 5 to 10 seconds so that it gains more stretches. And as it gains more stretches, it becomes less painful over time. All right. How do we establish this treatment? If it is piriformis muscle, you remember that this is exactly how we said earlier on that you can test for piriformis muscle tightness. You can also use the same method of testing as a treatment. In which case, this is where the pain is. You take the hip into flexion, the knee into flexion, and you put the lateral malleolus on the lateral side of the unaffected leg, and then you attempt to bring the lateral side of the knee close to the plinth. And as you are doing that, the patient will feel pain around the posterolateral aspect of the hip, of the gluteal region. When the pain is felt, you sustain the push there for 15 seconds, and you repeat 5 to 10 times. That will result into stretching the hamstring, and over time, that pain will disappear. The other way we can do the tightness of the hamstring stretching is to use this method of leg crossover. So the leg where the tightness is suspected will be crossed over the knee of the unaffected side, and the patient or the therapist could assist to push the knee close to the chest of the patient. While that is happening, the piriformis and the gluteal muscles here will be on the stretch, and that will reproduce pain. Once the pain is felt, the moment the pain is felt, the push will be sustained and for 10 to 15 seconds, and repeat 5 to 10 times. So that's it there. Gluteal pain or piriformis pain could be a source of pain in patients with dysfunction syndrome. And if the pain is coming from the posterior back extensors, well, the way to test for it is also the way to treat it. All we just have to do is a single knee to chest test, where you ask the patient to grab the back of the knee and pull the knee close to the chest until the patient will feel the pain in the back, in the buttocks, or the thigh, or any of those three structures. Then the patient will have to hold that for 10 to 15 seconds and repeat 5 to 10 times. So that is one of the Nobel way of dealing with dysfunction syndrome. So the tightness due to hip flexors could be stretched in a way by asking the patient to be on an inclined plinth, whereby the patient is lying prone, but the plinth is inclined in order to impose stretch on the iliopsoas structure, just the way you're seeing it here. Patient could stay there for 1 to 2 hours to get that stretch, and if that is the source of this dysfunctional lower back pain, it disappears. The iliopsoas could also be stretched by the two other exercises you are seeing in the diagram here. All right, the tight side will be the right knee in this patient, and the normal thigh will be the left. So all the patient have to do is to lounge forward on the unaffected leg in order to impose stretch on the iliopsoas on the affected side. The position will be sustained for 10 to 15 seconds and repeat 5 to 10 times. So if that is the source of the pain, then over time the pain will resolve. All right. If the tightness is due to hamstring, a tight hamstring, well, the treatment is just like the way it is carried out. It is called, the patient could result into using active knee extension test. Active knee extension, whereby he support the thigh and he try to push his knee into extension until he feel a stop. At that point where he feel a stop and the pain, he could maintain that position for 10 to 15 seconds, repeat 5 to 10 times. That will be useful, or the therapist could help to do that. Here you see the therapist trying to keep the knee and trying to use his shoulder to push the back of the ankle further into stretching the brown hamstring that you can see there. Or if the patient could not tolerate any of these, then you could simply ask the patient to lie prone with the knee over the edge of the plinth and then sandbag imposed, or sandbag placed at the back of the ankle. Sandbag and gravity will impose a downward push on the hamstring and the calf muscle, and that will result into stretching of the hamstring, as you can see in that diagram. So that's the way to stretch the hamstring muscles. For the derangement syndrome, we're going to talk about the derangement syndrome, the characteristics, and then the treatment. Now, first, what we have to understand is what is derangement. When we say patient is having derangement syndrome, then what is derangement itself? Derangement, or what we call internal derangement, is a situation whereby something is obstructing the normal posture of a joint, the normal posture or movement of a joint or bone in the body. So that obstruction itself is what is causing the internal derangement, right? So internal derangement, mechanical term, is a situation whereby another object is obstructing the normal posture or movement of a joint inside the body. For instance, a slip disc might be compressing on nerve roots. So that will mean when the patient do extension, there will be obstruction to the movement and there will be pain. Or it could be in the opposite direction, right? So that's derangement. And derangement causing lower back pain or cervical pain mostly is due to intervertebral disc herniation. Intervertebral disc leaving its normal position, thereby compressing on nerve roots. And compression on nerve roots can produce pain. It can produce muscle weakness. You know that those nerves, they are sensorimotor, and it could also cause alteration in reflexes. All right? But there are two types of derangement. There are some types of derangement that when they are treated, they get resolved. Or even without treatment over time, they get resolved. And there are some kind of derangement, no matter what treatment or movement you give, no matter what movement you give, derangement will not respond. And there are this type that if you carry out movement in certain direction, you will be able to resolve the derangement. So those derangements that are resolvable with movement are called reducible derangement. And those ones that are not resolvable with movement are called irreducible derangement. So we need to know this before we go into the detail of using McKenzie to deal with it. So in reducible derangement, anytime you ask the patient to do repeated movement tests, if the derangement the patient is having is reducible, anytime you ask the patient to do repeated movement tests, there will always be directional preference. There could be centralization or peripheralization. But in irreducible derangement, no matter what direction you use, no matter what direction of movement you use, the pain will remain the same, and you are not going to get centralization or peripheralization. Now, what do I mean by directional preference? If you ask the patient to do repeated flexion, and that eases the pain, but when you ask the same patient to do repeated extension, that aggravates the pain. So it shows that the patient has directional preference for flexion. But if extension is what eases the pain, you can say the patient have directional preference for extension. For some patients, it is lateral side flexion that will to the right that will increase their pain. Going to the left will increase their pain. So they still have directional preference. To some patients, it could be repeated flexion in lying that will reduce their pain. So it's still a flexion directional preference. Or it could be repeated extension in lying that will relieve their pain. So that will still be what? That will still be extension directional preference. So directional preference refers to specific direction of repeated movement. It can be forward or backward or sideways that reduces the symptoms or centralizes the symptoms. You know, like I told you earlier on, two things could happen when you are carrying out directional movement. The symptoms overall could reduce and it could move from more distal part to the more proximal part of the body. All right, this is also illustrating the concept of centralization and peripheralization. A strong indicator that directional movement is happening is when the symptoms is reduced or when the symptoms centralizes or peripheralizes. When do we say the symptoms centralizes? If you look at the start of event with this diagram, pain is in the lower back coming to the back, but after some repeated movement, the pain, or after some treatment, it might be McKenzie, it might not be McKenzie. If you carry out some physiotherapy treatment or manual treatment, at the end of the day, the pain that is in the lower back radiating to the leg, now localized to the back, will be said to have been centralized. And centralization is an indication that the pathology is resolving. It is also an indication that the treatment that the physiotherapy is administering is also working. The opposite could be the case, whereby the patient started with a little pain in the lower back, and at the end of the movement, repeated movement test, the pain has now come down to the leg. Or at the end of sessions of treatment, the pain has not come down to the leg. Such a pain will be said to have peripheralizis. And peripheralization is an indication that movement is making the pain worse, or the pathology is getting worse with our patient. So when our patients are doing repeated movement tests, we need to take note of directional preference and whether that occurs with centralization and or peripheralization. So how do we treat these patients after we have established that they fall into derangement syndrome? Those patients that have a directional preference for flexion will be treated with flexion principle. Those ones that have directional preference for extension will be treated with extension principle. And those that have directional preference for lateral side flexion, maybe right side lateral flexion, they'll be treated with lateral principle. Left side lateral flexion will be treated with lateral principle. Okay? So we're going to have to look at example of movement that fall under flexion principle. All right, one of such movement, if you notice that a patient has directional preference for flexion, you can give him treatment by asking him to do knee to chest exercise, pulling the knee to the chest, hold it down for about 5 seconds, then pull the second one, then repeat between the right and the left 10 times, 3 times in a day. So single knee to chest is an example of exercise you can use in flexion-based principle. Double knee to chest, or you can grab both knees together, put them to the chest, hold it down for 5 seconds, let it off and draw it again, let it off and draw it again, and so on and so forth. Flexion in standing could be another treatment we can give to patients that have flexion directional preference. Patient can bend down, hold it down and come up. Bend down, hold it for 5 seconds and come up if the patient can tolerate that position. Or we can ask the patient to do trunk rolling or knee rolling or trunk rotation. Putting both knees together, rotate it to the right and rotate it to the left with the shoulder and the palm facing with the shoulder stick on the with the shoulder glued to the bed and the palm facing and on the bed. So the knee could be rolled to the right and to the left, to the roll and to the left for a number of times. They are all examples of flexion-based exercise or flexion principle. Other example of flexion principle exercises we can use after we have established the arrangement is can ask the patient to hold on to the bar and then carry out hold on to the bar and carry out repeated squatting, or we can ask the patient to carry out repeated movement tests. They are all examples of flexion-based exercises. Extension-based treatments will include patient is good for patient that shows extension directional preference, and with those group of patients, we could simply put them to lie prone for hours and their pain subside. If they are good with that, we can make them to lie on their elbow. So that is more extension for the spine, and they can come from flat prone lying to lying on the elbow, repeated it sometimes. If they are good with about 10 of that, then they can go with prone on the elbow to prone on full elbow extension to be repeated 10 times. That will be repeated extension treatment. And that's extension principle treatment for patient that has directional extension preference. They could also practice repeated extension in standing, that's standing straight and leaning back, come back to neutral, go back to extension, and repeat that 10 times every 2 hours or at least 3 times in a day. That could also make the patient to feel better. Moving forward from there, patient could do extension in lying, EIL, extension in lying with self-overpressure. Patient could apply self-overpressure with a belt. I can put a belt around his waist where the pain is and get it stuck to the plinth or hold it with his hand in this position so that anytime he's reaching up, there's a little bit of pressure coming from the belt onto the area of the pathology. Or the overpressure could also be applied by the hand of the therapist while the patient is doing the extension. They are all examples of extension principle type of exercise. Then we could now talk about the lateral shift. So some of the patients that have discogenic pain, they have intervertebral disc herniation. When the disc herniates in one direction, compressing on the nerve root, it causes them pain in that direction, and automatically they lean their body away from that side and they walk like that. So walking in that manner is said to be a lateral shift walk. So a lateral shift is also known as acute scoliosis. It is a spinal condition where the upper body visibly shifts to one side, misaligning the shoulder over the hip. It's because of the pathology, the disc shifting in one direction, causing compression on the nerves, inflammation of pain-sensitive structure in the area, like you have in the shaded part, and that makes the patient to lean away to the opposite side. When you have your back pain patient coming like that, beside flexion principle, extension principle, you will still have to carry out a lateral principle treatment on them. And one of the main lateral principal treatments is to carry out lateral shift correction. How is the lateral shift correction carried out? Get the patient to come to stand with feet together, and the side of the pain will be next to the wall. So the shoulder and the elbow and the back of the palm on the affected side will get to the wall, and the patient will use the hand on the good side to push the hip on the good side towards the wall and hold that position for few seconds, 2 to 3 seconds, come back and go there again and repeat that 10 to 12 repetition 2 to 3 times a day. Or it could be therapist administered lateral shift correction, whereby the therapist stay close to the patient. The distal shoulder of the therapist will be close to the rib cage of the patient. We can see that in this diagram. That's exactly what has happened. And then the fingers of the patient will be interlocked and placed on the waist of the patient. Then the therapist will draw the hip of the patient towards herself, hold it for 2 to 3 seconds, allow it to go, and repeat the treatment 5 to 10 times. The therapist will have to stay on the side of the pain where the patient is feeling the pain. So either the patient carried out a self-slide gliding in standing, or therapist administer lateral shift correction. Both of them will be good for lateral principal movements. All right, now we come to irreducible derangement. Patients that have irreducible derangement, whether they do repeated flexion or repeated extension, it doesn't really affect their pain. Their pain remains the same. Such a patient cannot benefit from either flexion principle or extension principle or lateral principle of McKenzie treatment, but they could perhaps benefit. You can try traction on them, or you can try core stability exercises on this group of patients. Then we have to briefly talk about cervical pain before we finish. If a patient is showing a preferential or a directional preference of extension with the neck, then the exercises that could be administered to such a patient will include cervical retraction exercise with self-overpressure, whereby the patient pull the shin inward and push a bit further with his or her hand until end range is reached. Hold the position for 1 to 2 seconds and repeat 5 to 10 times, 3 to 5 times in a day. That will be for patient that shows directional preference for extension in the neck. Still in the neck, the overpressure could be applied by the therapist. So the patient will do the shin retraction. The therapist will support the lower back with the rear hand, and with the frontal hand, the therapist will apply overpressure with the shin traction that the patient is doing. Another extension-based treatment for patients that show directional preference for extension will be repeated cervical retraction with mobilization in extension. Patients will initially carry out retraction. That's why you have the arrow here. And with that retraction, she will slowly move her head into extension. Hold it down for 1 to 2 seconds, bring it back, and repeat the same 5 to 10 times. Still on extension-based treatment for preferential direction in extension for the neck problem, patient could also carry out sustained cervical extension in prone, whereby the patient lie prone, supporting the upper part on the elbow, and then push the neck into extension until the end range is felt, and the patient stay in that position for 5 to 10 seconds and repeat the movement again. You could also use his thumb or fingers to push the neck into extension until the end range is felt, and the position will be sustained for 5 to 10 seconds and repeated 5 to 10 times. If a patient is showing end of range pain, if a patient with cervical problem is showing end of range pain with side flexion, then therapists could come and move the neck into side flexion, the same side where the end of range pain is felt. That's what is called lateral flexion with therapies over pressure, and the therapist will sustain that for 5 to 10 seconds and repeat 5 to 10 times. If a patient is showing derangement, all right, let's look at the patient seated here. Now, this side here is the left side of the patient, and this is the right side of the patient. If a patient is showing derangement with pain, doing the left lateral side flexion, then the patient can also do the movement in the opposite way. You know, derangement movement goes away from the direction of pain. It goes away from the direction of pain to the direction where there is no pain. So this movement can be carried out to the right on this diagram if there is end of range pain at the right, or if there is derangement pain on the left. The same thing applies with rotation. If there is end of range pain on the right, then therapists could apply rotational movement to the right. And if there is derangement pain coming to the left, then the therapist will have to carry out rotation in the opposite direction. So that's how McKenzie is applied to the neck. Well, if a patient is showing preference, directional preference for flexion, which is neck pain, when you do repeated movement tests, then therapists can carry out neck flexion with therapist over pressure, as you have here, with the back hand. The rear hand of the therapist will support below C7, and the proximal hand of the therapist on the occiput will force the neck onto flexion until there's no more movement. And then that will be sustained for quite 1, 2, 3, 4, 5 seconds, and then repeated 5 to 7 times. The therapist could also, the patient could also carry out the neck flexion by herself. Could carry out the neck flexion by herself by rotating her neck to the side of the end of range pain or away from the side of the pain in case of derangement syndrome. Sustain it with her hand and holding it down for up to 5 seconds to be repeated 5 to 10 times. And finally, what are the contraindications to McKenzie method? The contraindications to McKenzie method include if you have a patient that no position or movement alleviate the pain. In other words, if the patient pain is not mechanical. So you could do well by asking the patient to go for further investigation. If a patient is having saddle anesthesia, i.e., there's no sensation around the anus. If there is extreme intensity of pain, patient cannot adopt any position to even allow you to do any exercise at all. Or if there is congenital or acquired spinal deformity. A very good example of that is spinal spondylolisthesis. It is a contraindication to McKenzie method. Well, I do hope you have learned 1 or 2 things, and I do hope you are going to try your hand next time when you have your back pain patient. You're going to try to inculcate this principle of assessment and treatment of McKenzie, and share the goal of your treatment with us online. Thank you very much, and see you next time.